Oh, me too.
Like everything.
All right, I'm going to turn my video off
Okay.
for the intro.
Hello, everyone who's already with us. We're just going to give it a couple of minutes because our participant numbers are climbing rapidly. So just going to give it a minute for everybody to join. Oh. Okay, I think that's my cue to get started. And I'm looking at the participant list and I see that we have our tweeter in chief present. So we're good to go. Phew. Hi, Johnny. I'm actually going to give it like 1 more minute because we are still climbing rapidly. Okay, yeah, maybe I will get going at least with intro so that we don't cut too much into our fantastic plenary speakers time. So yeah, hello everybody, I'm Janine Austin. I am Vice President RISE PG and I'm co-chair of this meeting. Very sad that it's not in Montreal, but you know, it seems to be going really well so far. I hope everybody's enjoying the content. And we do have a treat for you this morning. Well, morning for me, it's 6:45, not that I'm bitter or anything. Morning, afternoon, evening, wherever you are. Yeah, so we've got Dr. Lea Davis here to talk with us this morning. And Dr. Davis is an assistant professor of genetic medicine, psychiatry and behavioral sciences and biomedical informatics. Dr. Davis's work employs a population-level approach to the investigation of the genetic basis of a wide range of complex phenotypes. Her research aims to discover how polygenic risk, rare variant risk, and environment interact to result in common complex diseases. To accomplish this, she applies genomic and bioinformatic approaches to biobank data and phenotypes extracted from the electronic health record. In addition to her work on complex trait genomics, Dr. Davis has a long-standing interest in social justice, research ethics, genomic privacy, and data sharing. And just a shout out to yesterday's session that Dr. Davis participated in about racism and its interaction with psychiatric genetics. If you didn't get a chance to participate in that live yesterday, this is just a plug to do watch the recording because I think it was an incredibly valuable thing for our society. But with that, I'm going to hand over to Dr. Davis.
Thank you so much, Janine. All right, I'm going to share my screen. So, okay, how's that looking?
Fabulous.
Okay, great. Well, thank you for the lovely introduction. And I am really delighted to have the opportunity to speak with you all today, even if it is in this virtual format. And I'm even more excited to share with you the work of an entire community, the PsycheMERGE network, that has really been near and dear to my heart since we first came together in 2018. And I think has really helped to keep my spirits afloat over the past 2 years that have been so difficult. So I have a couple of disclosures as a consultant on grants for University of North Carolina and Texas. So in 2015, the Obama White House launched the Precision Medicine Initiative aimed at identifying the right treatment for the right patient at the right time. And until now, most treatments have been designed for the average patient. So as a result of this sort of one size fits all approach, treatments can be very successful for some and not so successful for others. So really the idea behind precision medicine was to take into account all of the individual differences in people's genes, their environments, their lifestyles, and to use that to improve precision to make better diagnoses and to match the healthcare needs with an appropriate healthcare treatment. And so similarly, it's been argued that precision psychiatry is an approach that integrates physiological, environmental, molecular, cognitive, and various omics data together to improve accuracy of diagnoses and to prioritize treatment options at the point of care. So of course, with the end goal of improving outcomes or prognosis. And in this very nice paper by Fernandez et al., they argue that one way to begin this journey is through the use of big data from sources that include electronic health records and genomics. And so it's really the central goal of the PsycheMERGE network to bring together electronic health record data along with available omics data to advance precision psychiatry. And while working in the EHR certainly comes with its own set of challenges, it's also importantly provided us with space to test out the translation of genomic medicine and prediction models before moving them into the clinic. So in this way, I sort of think about the EHR environment providing us a kind of translational sandbox to see how these models work in real life and what factors influence their performance. So over the next hour, my goal will be to introduce you to the breadth of projects that we're engaged in within the network, and for us to take a deeper look at some of the data and the results from those projects. And along the way, I will also try to point out some of the dangers of working in the EHR and how we're actually looking at those problems as potential learning opportunities. Because of course, many of the problems that we encounter in the EHR are also problems in clinical care and are just simply being reflected in our research designs. And then lastly, but probably most importantly, I want to share with you how this kind of pragmatic approach has impacted some of my perspectives on the challenges that we face in precision psychiatry, the opportunities, and just sort of what the perspective looks like from being very embedded in this type of research. So the PsycheMERGE network began in 2018 at 3 academic medical centers that all had EHR data available for research and had linked biobanks with genotype samples. And it has been really a tremendous honor to co-lead the PsycheMERGE network consortium with Jordan Smoller and Chris Chabris. And the 3 of us are so deeply grateful for the contributions of the community who have come together to form this consortium. And within just a few months, the PsycheMERGE network grew, and we now have over 21 sites. Not all of them are reflected on this map, actually, and affiliated partners, including international partners. So the consortium is built on the existing collaborative infrastructure of the eMERGE network, which stands for Electronic Medical Records and Genomics Network. And PsycheMERGE, of course, has a focus on mental health and psychiatric conditions. And we operate a little differently from the original eMERGE consortium in that we use a federated analytic approach instead of a centralized data approach. So this means that instead of bringing our data together into one central place, we bring the scientists together to develop centralized pipelines that then get deployed locally. And the results then can be meta-analyzed across sites. So there are really two fantastic things that come out of this, I think. The first is that we're able to pretty quickly and efficiently include hundreds of thousands of samples, which allows us to work at the scale that is needed to understand the kind of complex and nuanced biology that we're seeking to understand. And the second is that we really learn so much from each other. And this kind of egalitarian approach to research has really been a tenet of the consortium from the beginning. So the group includes more than 80 geneticists, data scientists, psychiatrists, psychologists, statisticians, project managers, software developers, ethicists, students, faculty, and staff. And we recognize that the kind of problems that we want to tackle are much bigger than any of us has the expertise to deal with on our own. And I think we all realize this, and we encourage each other to share what we know, but also to be vulnerable and open about what we don't know. And this really helps to create an atmosphere of intellectual honesty, where investigators at all career levels and with different backgrounds can contribute meaningfully, take a seat at the table, and we all walk away learning something from each other. So in total, we now have a network partnership of 21 academic medical centers, registries, and partner sites, over 80 collaborating members, and access to over 15 million electronic health records with almost 1 million genotyped patients. And in order to understand the types of research questions that we're able to focus on as a network, I want to spend a few minutes just giving you some background on the structure of healthcare in the United States and at our partner sites. So the intended first tier of healthcare includes primary care, which is generally concerned with promoting healthy lifestyle, counseling, education efforts, general public health efforts. The second tier would be health screenings and assessments to facilitate early detection of disease. And the third tier would include tertiary care, which is the treatment and management of disease or health conditions. Now, the majority of the centers in the network are providing primary and secondary care to generally to their local populations, but they are also known as tertiary care centers. Now, the reason for this is that academic medical centers are really the location for biomedical research in the United States, and these centers tend to concentrate expertise and resources, particularly in specialty tertiary care. So this means that when somebody's disease becomes so advanced that their community doctor needs to refer them, medical centers like the ones in our network are the site of that referral. So our patient populations include people receiving primary care and secondary care, but we are enriched for this level of tertiary care at all of these institutions. And you can actually see evidence of this ascertainment reflected in this plot of medical record lengths, for example. So here you're looking at a histogram of the length in days of about 3 million medical records at VUMC. And you'll see that a lot of people have short records. So this big spike, close to 0. And these would be the people who get referred from most likely their community doctor for a specialty tertiary visit, or maybe they enter the system through the emergency room. But there are many people who receive primary care at academic medical centers and stay in these centers for decades. So, so that you don't have to do the mental math, I have here a marker for 5 years and a marker for 27 years. So for these patients, we see them when they're healthy, prior to the onset of disease, for secondary care as they age, and for tertiary care if and when chronic disease develops. And what's more, in the sample of patients with linked DNA, there are even more enriched for this kind of primary care population. And this is because they actually have more opportunity to participate in the biobank when we see them over and over for their regular healthcare. So we also see this reflected in the average number of visits per year, which is also higher among patients who have been recruited into the biobank, again, reflecting more opportunity to participate. So here you're looking at the year on the x-axis and the average count, so average number of visits per year on the y-axis, and pink is our biobank population, green is everybody else in the medical record. So our average network medical record length is almost 5 years, but the network average medical record length for genotyped patients is about 12 years. And on average, we also have across the network around 6 visits per patient per year. Now, over a dozen work groups have developed out of the network. And while I won't be able to cover the tremendous work of all of them, and I would recommend if anybody missed the session this morning, there was a wonderful session chaired by Jessica Dennis and Rachel Kember on polygenic scores in the context of the EHR that highlighted the work of many of these groups. So please go back and check out that session as well. But I do want to highlight a few work groups and share some of the insights that their work has revealed. So I'll start with some of the phenotype-specific groups, beginning with a group studying PTSD, which is hard to recruit in research settings, but is not uncommonly diagnosed and treated in clinical settings. And so Carmel Choi is leading this work group together with the PGC PTSD group. And she's brought together sites across the network to determine whether EHR-based definitions of PTSD yield similar genetic findings, so heritability, genetic correlations, top hits, as the research ascertained samples. And the short answer is that by and large they do, although there are some interesting differences depending on how you define PTSD in the EHR. And this group is also investigating sex differences in the genetic architecture of PTSD and the co-occurring conditions that are often observed in patients who have experienced trauma. Now, along similar lines, an MSTP student in the lab, Ali Lake, is now also collaborating with this group to extend work that she has presented at this year's conference on mining social determinants of health from the medical record. Now, Ali focused on identifying sexual assault, and she found that billing codes are actually very infrequently used to indicate care associated with sexual assault in the EHR. Out of about 3.5 million people, only 7,000 encounters included codes for sexual assault. So she ended up developing an approach to search the free text of the clinical notes and identified over 14,000 disclosures. So her method had about a 90% accuracy, and it resulted in a 2-fold increase in sample size. And one of the really important things to come out of this work has been the ability to understand the risks to males who experience sexual assault, for example, as this is a very difficult population to reach. And Ali's work shows that while sexual assault occurs more frequently in females, some of the mental health outcomes may be actually more severe in male survivors, reflecting some lack of resources for male survivors of sexual assault. Another PTSD-related phenotype that's very hard to recruit in the general population, but is actually highly enriched in our epilepsy monitoring units, is functional seizure disorder. So Slavigolova, a recently graduated PhD student in the lab who is now doing a postdoc with Josh Denny at the All of Us program, developed an approach to identify patients with functional seizures at VUMC And then she worked with the partner sites in the PsycheMERGE network to implement that approach and to run then the first GWAS of functional seizures with almost 10,000 samples. And I should say 10,000 cases, actually. So the total sample size was over 350,000. So her work really established the first heritability estimates for functional seizures, and we're pretty confident that future freezes will reveal genome-wide significant loci. In addition to the PTSD and related phenotypes, a very active work group has developed around identification of opioid use disorders in the EHR. So this group is being led by Sandra Sanchez-Roig and Vanessa Troiani with partner sites across the network. And one goal of this group is to use EHR data to improve power in ancestrally diverse populations for the genetic study of opioid use disorder. But with access to longitudinal records, the group is also able to investigate the transition from minimal to chronic exposure to eventually OUD. And Annika Falcon, another wonderful PhD student in the lab, is also presenting work at this meeting on the comorbidities of OUD and the impact of whether she compares the patient population with OUD to an unscreened or exposed control sample. And I think that this type of work is really foundational for understanding the impact that these decisions will have on later genetic studies. So this brings me to one of the first sorts of realizations that I had about working in the EHR, which is that the EHR is a really powerful resource for research on stigmatized conditions. And I think this is also so important because stigma often results in a lack of research, a lack of understanding, which then just contributes to more stigma. And I think that this is a cycle that we have the ability to intervene on using these types of resources. Now, so far, we've touched on a couple of phenotype-specific work groups that are using simple definitions to identify possible cases. But we also have a work group that's focused on building and validating more sophisticated diagnostic algorithms using all types of data elements from across the EHR. So briefly, I want to mention what those data elements are. Typically in the EHR, we have access to billing codes, which are recorded to indicate the clinical visit, procedural codes, medications that are prescribed, narrative notes that the provider enters about the clinical encounter, emergency room visits, laboratory and path tests and results, and finally, inpatient visit data. Now, there's a lot of action happening in this slide, and there's a reason for that. So the point I want to make with this is that the healthcare record is actually very dynamic. It's constantly being updated, it's being touched by many hands. And so while the record itself is structured and electronic, behind that structure is a fundamentally human process. And so even before the development of PsycheMERGE, several of the partner sites had begun to utilize these kinds of dynamic data sources in the EHR to develop algorithmic approaches to identify people who might meet criteria for mental health conditions. Now, often the way this would work is that an algorithm might be trained using a set of features that's either identified through an outside resource, like literature mining or OMIM, for example, or on part of the data at a site. And then the results of that algorithm, the weights for different features, for example, can be then applied to an additional part of the data to determine a kind of probability score, which can then be compared to a gold standard clinical review of adjudicated charts. And this is then an internal validation of the algorithm. So when the network came together, one of the first things we wanted to do was to validate these existing algorithms across network sites so that we could try to harmonize our phenotyping approach. So we engaged some existing tools like PhyKB to standardize our approach for sharing algorithms and code. And then we created some new tools using software like REDCap to standardize our approach to the clinical chart review process. And yet, despite these efforts, when we looked at the cross-site performance of the algorithms, across the board, they were not performing as well as we would have hoped. So when we brought all of our data to the table and we got our clinicians who were doing chart review at each site to share their insights, we started realizing that one of the things that could be impacting the cross-site performance was the kind of local clinical culture related to the diagnoses that we were attempting to identify. And you heard some examples of this in earlier talks this morning as well, and in the talks that Janine referenced yesterday. So clinical culture here would include things like tests that are ordered or diagnoses that maybe are ruled out before a psychiatric diagnosis is considered. And any of that information can then become a feature in the development of an algorithm. So for example, if at one institution, it's common practice to rule out a vitamin D deficiency before diagnosing major depression, but that's not routinely done at another institution, then the features that are useful in one clinical culture may not be useful at another clinical site. And this means then that an algorithm trained at one site might not perform as well at another site. But it turned out that this was not the only source of variation between the sites. And so while the diagnostic algorithm group was grappling with this, another important group, the PsycheMERGE Diversity Initiative, came together, led by Roseanne Peterson and Rachel Kember. So the initial goal of this initiative was to improve diversity in genetic ancestry across GWAS studies of psychiatric conditions. But in order to include the full richness of genetic diversity, the group recognized that it had to ensure quality diagnoses across diverse racial and ethnic groups. And this is really where the synergy between the diagnosis and the diversity group took off. And so starting with our bipolar disorder algorithm, we found that there were actually significant racial differences in the proportion of individuals who either met the probability threshold to be defined as a case, or who had features involved in that algorithm definition. And at some sites, there was up to a 48% difference between racial groups. So this both reflects and creates problems, right? It reflects the fact that there are disparities in how different racial and ethnic groups are being diagnosed. And because of this, it then creates a new set of problems. So first, that we could propagate this disparity into our research. And second, that when there are demographic differences between sites, this issue then also contributes to poor cross-site validation. So when we begin examining the racial and ethnic differences in the assignment of diagnostic codes that are used in these algorithms, we saw that, for example, in this plot, you can see that the proportion of people who had ever been assigned these codes, here we're looking at an example of bipolar disorder as a feature and hypothyroidism, that the proportion of people who had ever been assigned these codes varied dramatically across the racial and ethnic groups, and that the frequency with which, once they were assigned, they continued to be assigned those codes also varied. So I should say that Laura Huckin's group has published some really superb work on the ways in which human bias makes its way into structured data in the EHR, which can then lead to biases in diagnostic and prediction algorithms. So Karina Sia, a MD PhD student in Laura's lab, gave a wonderful talk on this in the ISPG Ethics Committee Symposium yesterday. So if you missed that, I would suggest returning to that recording. And so this is now something that we are working on as a collaborative, and I hope that this will have impacts not just on our EHR-based algorithms, but also a deeper awareness of the systemic nature of the problem that can become then a part of the learning healthcare system. This is one of those examples in which I think there's really shown an incredible value in seeing how the delivery of care actually occurs in real life. And this leads me to the second sort of foundational perspective shift that I've had since entering the world of sort of EHR-based psychiatric genetics, which is that precision psychiatry, with all the potential for, fancy artificial intelligence tools and integration of genomic medicine, which is really exciting, is actually not going to yield much unless it's built on a very strong and equitable foundation of public mental health. And to me, this means that we really have to examine how mental health care is practiced. And then this also becomes a question about public health access and equity. And I think it is part of our job to get involved in those conversations. For example, we also have found that locally, so at VUMC, we've observed that for mental health conditions with long diagnostic odysseys like bipolar disorder, the more financial resources a person has, the more likely they are to receive that diagnosis. And this isn't because wealthier people are more likely to have mental illness, but because they're more likely to have the resources they need to get an accurate diagnosis. So I think even beyond the genetics, there is actually tremendous value in conducting psychiatric research in the EHR because clinical care is actually woven into the data itself. And we can use this knowledge to create a stronger foundation to see where are the gaps and what do we need to focus on in public mental health and in all levels of clinical psychiatric care. Now, everything that I've been talking about so far has been phenotype focused. So at this point, I'd like to pivot towards the integration of genetics and tell you about some of the work that we've been doing primarily with polygenic risk scores. Now, so here's work from one of our first genetic studies within the network. This was published in 2019, and it demonstrates that the polygenic score for schizophrenia, just using a simple schizophrenia fee code definition, was actually strongly associated with schizophrenia across 4 of the PsycheMERGE sites. We then also conducted a phenome-wide association study of that polygenic score. And so a phenome-wide association study is sort of the inverse of a genome-wide association study, where instead of comparing cases and controls for one phenotype at every position in the genome, here we're taking one single polygenic score and we're asking, is it higher or lower on average for cases or controls across about 1,500 different phenotypes. So these studies are performed on everyone in the biobank, regardless of whether they have schizophrenia or not, because of course, everyone has genetic risk for schizophrenia. So we do this in a regression framework to adjust for standard covariates, including age, sex, principal components from the genetic data. And so in this Manhattan plot, you can see that each dot represents a phenotype. The phenotypes are organized on the x-axis by domain, and the y-axis reflects the negative log 10 of the p-value. So here we see this peak of psychiatric diagnoses associated with the schizophrenia risk score, which actually remains even after we adjust for the presence of psychosis or schizophrenia or any antipsychotic medication. And we also see associations with metabolic conditions that again, and genitourinary conditions that again remain after we adjust for the presence of schizophrenia. For the MDD risk score, we see a similar sizable peak in the psychiatric diagnosis category. And we see additional associations with cardiovascular disease, respiratory, and digestive conditions. And interestingly, when we adjust for the presence of depression or major depression, we still see strong enrichment in the cardiovascular disease space. And in fact, for every psychiatric polygenic risk score that we've tested so far, we generally observe the greatest odds ratio for the referent phenotype. And even when we control for the clinical diagnosis of that condition, we still see widespread association with the polygenic score across the phenome. But the patterns are different. So we see depression and cardiovascular disease correlated at the genetic level, anxiety and asthma-related phenotypes correlated at the genetic level. schizophrenia and metabolism, metabolic related conditions, and PTSD and chronic pain related conditions. And we think that these patterns may actually be pointing us towards some relevant biology. So this leads to kind of the third big picture idea, which is that both widespread pleiotropy and comorbidity are the rule, not the exception. And now keep in mind that we are working with the biobank population, right? So here we are enriched for those long records, primary, secondary, and tertiary care. So we're seeing the cumulative effects over many years. And in fact, most people actually receive their depression code before the age of 50. After the age of 50 is typically when we see a lot of these, for example, cardiovascular conditions arise. So taking another look at the depression polygenic score, so this is just a QQ plot of the same Manhattan plot that I just showed you. We find that after conditioning on depression, that score is independently associated with about 6% of the medical phenome. But depression itself is associated with about 90% of the medical phenome. And that is just staggering. So to give you some context for interpreting this, I can tell you that obesity is associated with about 60% of the phenome, tobacco use disorder, about 70%. Depression is far and away associated with more comorbidity than any other major public health issue that we've looked at. Now, there are a lot of complex interactions that are leading to this, but as we're interested in understanding the biological roots of this transition from genetic risk to clinical manifestation, we asked ourselves, is there additional information that we can pull out of the EHR to help us understand what may be happening systemically when we go from genetic risk to clinical manifestation of depression? And so more specifically, can we use some of the existing clinical biomarkers to help us understand the biological development of psychiatric conditions and maybe of their comorbidities? So what we want to do here is actually combine the longitudinal nature of the clinical labs with the genomic data that's available. And to give you a sense of the scope of lab measurements, which I have to say was really like astonishing to me when I first got involved in this research, there are about 11,000 different lab tests that are available at participating sites across the network. Now, anyone who has spent any time working with labs in the EHR knows how messy this data is. And I won't bore you with the details, but I will say that we spent about 2.5 years developing tools for the cleaning, harmonization, and analysis of lab data. And these tools, Quality Lab and LabWAS, are now available in our Bitbucket repositories. And I'm excited to say that they have been used to clean and analyze over 1.3 billion measurements on about 11,000 tests performed on almost 4 million individuals at 4 institutions in the PsycheMERGE network. So I'm going to tell you a couple of stories about some of this work. This is work that was really a project that was taken on and championed by Jessica Dennis when she was a postdoc with me and Nancy Cox, and a very talented grad student in the lab, Julia Seelock, who will be graduating in the spring. So they conducted LabWAS, which is similar to PheWAS, except that instead of diagnosis, we're screening against all of the routinely collected laboratory test results. And so using lipids, they first generated polygenic scores for LDL, HDL, triglycerides, and conducted several proof of principle studies to demonstrate that the scores for the labs themselves were robustly associated with the referent lab. And I won't go into the details of those studies, but I do want to share with you the results from their study of the genetic risk score for coronary artery disease, or CAD, as a first proof of principle. So this was also work that I'm showing you here in this slide that was conducted by Kira Adkins, another wonderful grad student in the lab who just defended her dissertation, and Peter Straub, program applications developer in the lab as well. So our primary question here was, can the genetic risk for CAD actually recapitulate the CAD biomarker profile? So we tested that question using this LabWAS framework with the CAD polygenic risk score. And here you're looking at an analysis performed in about 70,000 individuals of European ancestry, primarily European ancestry, and about 15,000 individuals of primarily African ancestry in the panel on the right. And yes, we did observe several canonical biomarker associations, including known risk factors like LDL, triglycerides, blood glucose, but we also observed markers of heart damage like troponin and BNP, which are elevated after cardiac events. Now, I mentioned that these analyses can include everybody in the biobank, and of course, some people in this data set actually have a diagnosis of coronary artery disease. So similar to what we did with the earlier PheWAS, we included a covariate for the CAD diagnosis. And what we saw was that the risk profile remained. In fact, some of the known risk markers like pre-med LDL became more significant despite the loss of power and achieved statistical significance in our African ancestry population. And we lost association with several of the markers that were markers of manifested coronary artery disease. So this was very encouraging that the approach could be used to identify both risk markers and consequence of disease. So then Julia returned to the depression polygenic score, and again, trained a polygenic score using the Howard et al. Summary statistics and deployed it in the LabWAS framework. And again, within the European ancestry sample, we see a number of associations. I should say that there were no associations that exceeded the Bonferroni correction in the African ancestry sample. So I'm going to continue to focus on the European ancestry population here. But I do want to note that although the point estimates for several of the labs were very similar in the African ancestry sample as they were to the European ancestry sample, but those confidence intervals were much larger because of the smaller sample size. So I do think that this is really still just an issue of statistical power, like we saw in the CAD work. So again, we observed associations with several metabolic traits, vitamin D, and multiple immune markers, including white blood cell count, absolute monocyte count, and absolute neutrophil count. So again, we adjusted for the for the presence of depression. Then we corrected for the presence of depression and anxiety. Then we corrected for the presence of depression, anxiety, adjustment reaction, and a median BMI. And we were impressed that the white blood cell count marker continued to show a robust association even after all of these adjustments. So we began to focus in on this association a little bit more. Now, we were really interested in this question of whether the genetic risk for depression itself actually contributed to a risk in inflammatory markers like white blood cell count. But remember, we just talked about the fact that depression is correlated with 90% of the medical phenome. So we could imagine many possible ways in which the genetic risk for depression could be confounded by or mediated by those correlated phenotypes. So Julia identified all of the phenotypes that were correlated with both the polygenic risk of depression and with white blood cell count. And in total, there were 40 phenotypes associated with both. And they could be classified into these 7 domains. And so she then went through a series of sensitivity analyses and adjusted for the presence of each. And lastly, adjusted for the presence of all of them. And still, the association between the depression polygenic score and the white blood cell count remained robust. So then we turned to the rest of the network, and within a relatively short period of time, like a matter of a month to 6 weeks, it was kind of astonishing. We were able to replicate the findings across 3 additional sites, all of which demonstrated the same degree of association between depression and polygenic risk and white blood cell count. You'll see, of course, that the confidence intervals around the BioMe sample is much larger because of the smaller sample size, but the point estimate was pretty similar to those at the other sites. And then in this situation, having access to individual level data was an additional benefit because we were able to test two mediation models, one in which white blood cell count acted as the mediator between genetic risk for depression and the clinical diagnosis of depression, and one in which depression acted as a mediator between genetic risk and the white blood cell count marker. And we actually observed evidence for both, which we think supports a bidirectional model between depression and inflammation. But it's important to understand this in context. So overall, we're seeing a very modest effect of genetic risk of depression on white blood cell measurements. Between the top decile of polygenic risk and the bottom decile of polygenic risk, it's only about a 5% difference in the median white blood cell counts. And importantly, these values remain within the white blood cell reference range. So our interpretation for this is really that the depression polygenic risk score is associated with increased but not abnormal white blood cell counts. And again, turning back to that question of comorbidity, so I showed you in previous slides that that the polygenic score for depression was associated with coronary artery disease. We've done additional work on that to rule out possible confounders. And now Kritika Singh, another wonderful grad student in the lab, has a fellowship from the American Heart Association to focus on this relationship. And it turns out that the increase in white blood cell count actually accounts for about a third of the increased risk for cardiovascular disease that's due to the depression risk score. Now, I should caveat that by saying the risk of cardiovascular disease that is due to the depression risk score is low. So it's like less than 3% of the variance that we're explaining. But about a third of that explanation is mediated by this increase in white blood cell count. So we think that genetic risk for depression is maybe increasing the risk for cardiovascular disease in part through inflammatory mechanisms. So our previous take-home message was that both pleiotropy and comorbidity are widespread, but now I want to take that one step further, sort of conceptually, and suggest that actually at a biological level, in many ways, mental health is really not separable from physical health. And I think that actually genetics gives us a nice framework to deepen our appreciation of this. So for example, what if what we call cardiomyopathy in the heart is actually driven in part by the same sort of inflammatory mechanisms as what we call depression when those inflammatory mechanisms affect the brain? It's more than saying that, these things are related and that relationship is important. It's really a change in the worldview of the nosology and classification systems of mental and physical health that have been overlaid on top of what is actually happening in our biology. Now, of course, mental health can have independent effects on physical health through behavior and vice versa. But I think that we actually tend to ascribe maybe too much causality in that direction, and probably not enough weight is given to the potential for pleiotropic mechanisms to have profound effects that may be small in magnitude at any one point in the lifespan that we're examining, but over a lifetime can accumulate in ways that have systemic impacts on the body and the mind. And I think the EHR is a really just uniquely wonderful, powerful environment in which to study this. And this point of view is also, I think, supported by clinical outcomes research. So we know already that when mental and physical health are coordinated, there are lots of positive outcomes for patients, including improvements in both mental and physical well-being, fewer costs incurred by the systems, So I think, really we know what we need to do, and it's actually a simple idea. It's simple, but it is not easy. We've historically siloed mental health care away from physical health care. So this is a table from the American Board of Family Medicine that reports the percentage of family physicians in primary care who work alongside psychiatrists. And you can see this percentage is really quite low, less than 15%. But if we're going to have precision medicine, we are really going to need precision psychiatry. And I think that at some point in the future, precision psychiatry will eventually be integrated into all of the domains of precision medicine. And I think that genetics actually offers us a bridge to engage in this work together. And so the last big point that I would like to make is that I think it's really abundantly clear that we need each other to work at scale, at a scale that can actually capture the kind of nuanced and really complicated biology that we need to understand in order to get to precision psychiatry and precision medicine. And so, again, I would like to just acknowledge all of the members of the PsycheMERGE consortium. I wanted to leave plenty of time for questions and discussion. And so I also want to, as we come to the end, acknowledge all of the members of my lab, recognize, again, the wonderful partnership between myself, Jordan, and Chris, recognize our funders, and lastly, I want to mention that there, like I said before, there are several other projects that I wish I could have shared with you, but we only have an hour together, and I did want to leave plenty of time for questions and discussion, and I think we have about 10 minutes for that. So I'll stop here, and thank you very much for your attention.
Thank you so much for that, Lea. I don't know if you could see while you were talking, but the Q&A box is kind of going bing, 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 bing. So I'm glad you left time.
Okay.
Yeah, so just in case anybody is freaking out and you're like, what about my question? Please put them all in the chat box, because our partners at Parthenon will keep track of them all, so that when we move into the next room for the chat with Lea about the talk, everything will be saved. So please keep using the chat box, the Q&A box, sorry, Q&A box. Yeah, but we will get started with some of the questions that came in. Let's take them in sequential order. So first question was, I wonder if you considered harmonizing data using a common data model such as OMOP created by the OHDSI community. Would not address all the issues you are highlighting, but would address some or many of them.
Yeah, that's a great question. So actually, all of the sites are using the OMOP data models. The issue is that I think for many of the sites, there are levels of access to data. So for example, at some sites, there's a sort of centralized data management process. And then what analysts are able to receive is then ICD codes, for example. And at other sites, they have a deeper level of access to data, including sort of structured OMOP tables and the ability to do that kind of harmonization work at a deeper level. So I think in the future, we will definitely, when it comes to algorithm building, and particularly to identifying concepts that are embedded within notes, we will absolutely be using the OMOP resources. So far, everything that I've showed you has really relied on ICD coding.
Right, beautiful. So hopefully that answered your question, Susan. So I'm going to move on to a question from James Walters, who says, such good talk, Lea. I think we all agree.
Oh, thank you.
Do you think there's an opportunity to examine the part played by disparities in healthcare provision by contrasting biases across different systems of healthcare delivery, for example, insurance versus social-based? There are still disparities in social health systems, e.g. for ethnicity and psychosis in the UK, but could this comparison help quantify the contributions of health service design? Of course, comparing EHR across countries will be fun. Yes.
Yes, I think that is a wonderful point, James, and I totally agree. And this is one of the things that I'm really excited about engaging more with some of the international partners on this question exactly. And I think that actually there is the potential for us to make some really compelling policy arguments when we're able to do that. So I think it's an excellent idea and definitely a needed area.
Lovely. Okay, cool. Next one's from Jimmy Potash, who begins, "Superb talk, Lea." Again, agreed. Thank you. I'm quite intrigued by the depression PGS correlation, as are we all, I think, with medical conditions. It would seem to have implications for the causal relationships between these disorders. Has this been published yet? Can you point us to the paper?
Yes. Okay. So the association between the depression polygenic score, and actually I didn't focus on this, but also the loneliness polygenic score that has been published. That was in Molecular Psychiatry. I think it came out in 2020, and Jessica Dennis and Julia Seelock are co-first authors on that paper, and they really did just tremendously careful sensitivity analyses, trying to make that association go away in any possible way that they could. They also then ended up replicating it in the Framingham study. So there's really, I think, some very compelling evidence now for a real biological relationship between these conditions that is in part, at least, driven by shared underlying genetic architecture.
Lovely, thank you. Okay, the questions are still coming in. It's brilliant. Next one is from Takahiro Soda. Hi, Lea, thank you for all your work on this. A delayed question, RE bias. Do you have any thoughts on how one might be able to take the EHR-based confirmation of biases in diagnoses back to the clinic to reduce these disparities?
Yeah, I mean, this is something that, I think a lot of us have been thinking about. I think that there is the potential for actually the development of tools that can help to reflect back to the clinician their own patterns of either thinking or diagnosis. But I think that before anything like that rolls out, which I would imagine would be probably at least a couple of years, the first thing is just an awareness of it, honestly. I think going into the clinic with an awareness of the fact that we have all been stewing in a system of systemic racism, and none of us are immune to that. And it will show up in small and sometimes large biases that we maybe are not aware of. So just maintaining some, I think, cultural humility around that, and recognizing that it is so deeply ingrained and embedded that there's no way that any of us are free of it, right? So I think that would be number one. And then number two is, that I think we can actually develop tools to help clinicians identify these patterns in their own practice.
Great, thank you. And a quick follow-up question from Taka also. And RE lab markers in depression, did you control for medication, for example, antipsychotic use?
Yeah, that's a great question. So we controlled for the presence of any kind of psychiatric diagnosis. And I'm trying to remember actually whether we included medication. I don't think we did in that analysis because like the lab data, the medication data was also very messy, and it's taken some time for us to clean that data and work with it to actually even just get it analysis ready? So I think that is still an outstanding question for us with respect to the immune phenotypes. Yeah, good question.
Cool, lovely. And then one from Laura Ramsey. Are pediatric patients included in PsycheMERGE?
Yes, yeah. I mean, across all sites, there, pediatric patients are not excluded. Although I will say that there's definitely underrepresentation, and that's partially because of the ascertainment into the biobanks. So for example, at Vanderbilt, the way that someone joins the biobank is, they after, giving informed consent, any leftover clinical blood draw with leftover blood can then be banked. But kids, of course, get less blood drawn. They have fewer blood draws, and then even when they do have a blood draw, there's less volume drawn, and so it's generally less likely that they end up in the biobank, even when parents consent. So they are there. It's not a huge sample. I think in the Vanderbilt sample, it's I want to say under 10,000 of our 100,000 are pediatric. Yeah.
Great. Okay. Mark Adams. Can we use EHR longitudinally to disambiguate cause, effect, and confounding between physical and mental health?
Yeah, I think that is an excellent question, and it's one that we're thinking really hard about. So we are working on longitudinal modeling. It's challenging though. I mean, longitudinal modeling is wonderful when you have repeated measures, right? And there's a great framework already existing for that. But when you have different diagnoses entering into the longitudinal data, it's harder to conceptualize how that fits into our existing longitudinal models. So I think it's certainly an area that needs more methods development. It's definitely something that we're really interested in and working on. And I would also just like to say, given that point, that I think sometimes this area of EHR based genomics can seem very insider outsider, right? So you have to have access to the EHR to be able to engage. But I think that actually there are lots of ways in terms of methods development, simulation of data, that people who are interested in working with this data can still get involved, even if they don't have access to an EHR at their own site. And then, of course, there are other publicly available data sets like UK Biobank and All of Us, and some of the other big biobank type collections. Yeah.
Lovely. Okay, well, I've just looked at the time and we are actually quarter to the hour, so we're going to have to shut this down. I'm so sorry. So everybody who's typed their fantastic questions, I've had a bit of a look ahead into the Q&A box. Please don't panic. We're going to take them with us into the next room together. And if you want to join us there, you can actually ask your own question in person rather than have it run through me. So yes, please join us there in just a second. But I'd like to finish just by thanking Lea so hugely for such an incredibly thought-provoking and fantastic talk.
Oh, thank you so much. This was such a delight.
Yeah, it was really fun. See you in the next room in a sec, everybody. Okay, bye.
Bye.